So it's my pleasure to introduce Dr. Adam Vogel, Professor of Surgery and Pediatrics at the Texas Children's Hospital. Dr. Vogel completed his medical school at University of Rochester and general surgery at University of Chicago, and then followed 2 fellowships, one in pediatric surgery and another in surgical critical care at the University of Texas in Houston. His clinical practice focuses on pediatric general and thoracic surgery as well as surgical critical care, and he is currently the director of the surgical critical care, ECLS, and CDH programs at TCH. He is now also currently the chair of the APSA Surgical Critical Care Committee. It's my pleasure to introduce Dr. Vogel, who will be talking about fluid overload. Is crystalloid the devil? Yes.
Thank you. There we go. Thank you, Pramod. Thank you, APSA, for giving me the pleasure of the podium to talk to you about this. Crystalloid is the devil. That's where we're going to start. That's where we're going to end. But really what this is again, no conflicts of interest. It's to provide a little more information for everyone in the room so that we can be better advocates for our patients when we go into the ICU and talk about our critically ill kids that are suffering from fluid overload and acute kidney injury. So the goal of this talk at the end of the day is to give you some ammunition, some data, so when you walk into that ICU with all the beeping and all the craziness, you can advocate for your kids with your intensivists. We'll end with the beginning. So fluid overload is bad. Acute kidney injury is bad. Prevention is key. It's probably the most important thing. And we'll show you some data that there may be some benefits in children for early continuous renal replacement therapy. I'd be remiss if I didn't start talking at least a little bit about trauma and hemorrhagic shock. I feel that Rob Russell would reach out from the virtual world of Alabama and like kick me somewhere I don't want to be kicked. If I didn't say that, salt water is for cooking pasta, not for resuscitating hemorrhagic shock. Some of the great work of Stephanie Polides, the more crystalloid we do in resuscitation of our trauma patients, the worse the outcomes. But what I've learned in all this is you can't use blood products for everything, and honestly, they're not indicated for everything. So sometimes the devil you know is actually better than the devil you don't, and there actually is a role in resuscitation for crystalloid. I feel like I should almost leave right now, but we'll keep talking about it. The adults have done a really good job at this as far as determining which of the different devilish salt solutions are a benefit. There are 2 large trials, one in critically ill ED patients, one in critically ill ICU patients, looking at a balanced buffered solution, so things like lactated ringers, compared to normal saline. And when you look at the results of these big trials, in general, when you look at things like mortality, there's really no significant benefits. But when you look specifically at renal injuries, so the major adverse kidney events, either 30 days, 90 days, it tends to favor lactated ringers or the buffered solutions. Now in kids we're usually about 10 to 15 years behind all of the adult critical care things. There are some reasonable data, reasonable studies out there, mostly retrospective, some multi-center, that generally agree with that. There is, however, ongoing a multi-center randomized prospective study looking at lactated ringers versus normal saline in pediatric sepsis resuscitation, because that's where this seems to have the biggest event. So we hope to have this answer soon. So if we're not in hemorrhagic shock and we're resuscitating patients, LR really seems to be the solution to go with. And just as a friendly reminder of kind of what the resuscitation phase looks like, right, the ebb and the flow of a critically ill patient ongoing, you've got that initial resuscitation phase where we're really pouring fluids into these kids, looking to stabilize the hemodynamics. That transitions into more of an optimization phase where we're starting to tinker things are starting to settle out. Then there's a stabilization phase and eventually an evacuation phase. And it's that top part of that graph, there we go, we got the pointer here, we'll really start talking about fluid overload. And so what is fluid overload? So fluid overload, work in Houston, it's not rocket science, even I can process this equation. Fluids in, fluids out, divided by your weight times 100, that's your percent fluid overload. And so you can actually track this day by day for a total hospital course in Epic or Cerner, little buttons you can click that give you this information that can give you a sense of where your patient is from a numbers standpoint. Obviously, you're looking at your patient and you're seeing what those effects are. So that's where fluid overload is. And fluid overload is bad, right? We know this. It hits the brain. You get encephalopathy, You get encephalopathy, you get delirium, the heart, congestive heart failure, cardiac muscle wall edema, the lungs, probably the easiest thing, pulmonary edema, stiff lungs, longer intubation, risk of infections, the intestine. Everyone here is an expert on this, right? You get these volume overload kids, this big, thick, nasty intestine. You can't really cut it, you can't anastomose it. Ileus, intra-abdominal hypertension, abdominal Cartman syndrome, bad, bad, bad. Kidneys, acute kidney injury, electrolyte imbalances, muscle, skin, all these anasarcatus, I'm not even sure if that's a word, kids, that we go with, bad, 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 and the data backs that up. So large meta-analysis, systematic review, whether you look at fluid overload as either a categorical or a continuous variable, whatever population we're talking about, sepsis, lung injury, whatever outcome, vent-free days, anything along those lines, worse outcomes with fluid overload, and that's not surprising. So where can we make a difference in how we take care of these kids? So this was a study done at Texas Children's Hospital looking at about 100 ICU patients, looking at what kind of fluids are we actually giving them. So you see, they looked at their fluids on day 1 and day 3, and you see this big total fluid box, and what they did is they broke the fluids up into essential fluids and sort of modifiable fluids. So modifiable fluids would be things like drugs that you're giving the patients, the IV products, things along those lines. And so what this represents, at least for me, is that there's this big chunk of fluids that's modifiable that we can work with. And we'll talk a little about what we can do with that in a hot second. Acute kidney injury is also bad. This is how we stage it. We use creatinine and urine output. The more the rise of the creatinine, the worse your acute kidney injury is. The lower your urine output, the worse your acute kidney injury is. I throw that up there just, if your patient's creatinine goes up by 0.3, that's acute kidney injury. Now, so think about your kid that maybe had a lab back a few months ago and it was 0.3, kid comes in, it's 0.6, kid has acute kidney injury. And when you look at what the implications are in these critical populations, the relationship that creatinine has with urine output, they just kind of multiply on themselves. So large study, no severe acute kidney injury, just a rise in the creatinine, just a rise in the urine output. This is the Kaplan-Meier survival if you got both. Acute kidney injury is bad. How bad is it? So this is a study, Texas Children's, almost 200,000 patients of clinical encounters, stage 1, stage 2, stage 3. The higher the stage of the acute kidney injury, the worse the risk of mortality, significantly so. And not surprisingly, the more acute kidney injury events that you have, the worse your outcomes are. Fluid overload, bad. Acute kidney injury, bad. So how do we tackle this, right? Prevention is the key. One of the things that we can do is actually try not to give these kids a whole bunch of fluids. Wouldn't that be kind of nice? And so just a plug for Vince Duran from Columbia's study, multi-center, randomized controlled trial, protocol-based fluid therapy compared to a liberalized fluid therapy in post-operative patients and trauma patients going to the ICU. He's looking for friends to engage in this, so if this is of any interest to anyone in the audience, please give Vince a call. But when we go back and thinking about prevention, right, there's the resuscitation phase, right? We have these kids, they're tachycardic, they're hypotensive, their urine output is low, we start giving them fluids. We put them in an ICU monitored environment, right? You want to see what their physiologic parameters are doing. You want to see what their heart rate's doing, what their blood pressure is doing, what their urine output is doing. We're going to check a lactate. Somewhere I think Dr. Levine would know we should invent the lactometer to be able to track that, long-term, in real-time events for measures of our resuscitation. You can grab the ultrasound. My partner, Howard Pryor, loves POCUS, loves to bring that ultrasound up into the ICU. Look at the cardiac function, seeing how they're responding to their fluid administration. Look at the IVC compressibility. We have all sorts of tools that we can do to help guide our resuscitation so we, kind of like Goldilocks, we give them what we need, not any more, not any less, to really help them out. Prevention is key. So when you get in that resuscitation phase, using all those parameters are really helpful for knowing when you can start slowing down. You can go into that optimization phase part to it. Other things we can do to be preventative. Renally dose our medications. Find your neighborhood ICU or floor pharmacist, look at what the patient's getting and go, is that appropriately dosed for what the urine output is, what their creatinine is? Prevent acute kidney injury. De-escalate antibiotic therapy, right? We do these 48-hour rule-outs. They're getting a whole bunch of antibiotics. They're often IV. If we can de-escalate the antibiotic therapy, that's less volume that our patients are getting. Switch from IV fluids or IV medications to enteral medications. Anything that we can do to that helps prevention. Recognition, also super important, right? You go in, you see these kids, what do they look like? Are they getting edematous? You know, if you're walking by the vent in say the peak pressures were in the teens yesterday, but now they're in the upper 20s, what's going on with that? You know, are we seeing the effects of fluid overload? Paying attention to the labs, paying attention to the I's and O's, really get a sense of if you're seeing that positive trend, plus 100, plus 200, plus 500, and things aren't going down, those are patients that are at risk for all of these problems and worse outcomes. What can we do about treatment? Right, so we talked about some of those preventative strategies that are out there. I'm going to use a 4-letter word, but I'm not really. It's called Lasix, which is, you know, I think Dr. Stair was going to yell at me for talking about that. Diuretics can be our friends once we're out of that acute phase and they're appropriately resuscitated. And Dr. Fisher's also giving me bad, evil eyes. Right, the loop diuretics are often great first-line therapy, whether it's by intermittent bolusing or continuous, really depends on how the patients are responding. Sometimes those, your patients that are kind of just teetering on the volume status, you give them an intermittent dose of Lasix, they dump too much fluid, they get tachycardic, they get hypotensive, you just wind up giving it back. Sometimes continuous infusions are the way to go. Sometimes they don't respond, and you have to add another diuretic like a thiazide, which can work in combination. But in general, when you look at the data, the recommendations, all those things that are out there, diuretic therapy really is the first line in conjunction with all of those other preventative measures. So all that works, right, when the kidneys are working, when the kidneys are functioning. But what happens, right, when they're not? What about renal replacement therapy? Well, again, like we talked about earlier, the adults are way ahead of us in this. So we've got 5 really good trials in the adults looking at early versus late initiation of renal replacement therapy in critically ill patients. The first one up there, the Elaine, was actually done mostly in surgical patients. What does that mean, early versus late? So whatever the entry trigger was for the study, usually it was some sort of kidney injury, maybe stage 2, maybe stage 3, maybe a urine output, something on those lines. Early was typically going on CRRT at the time of enrollment or within 12 hours, and the later groups tend to be when they met whatever hard indication would be typically for renal replacement therapy. So hyperkalemia, fluid overload greater than 20%, uremia, things along those lines. And when you take a look globally at all the results of that data, it kind of says really no difference between early versus late. But again, the devil's in the details. So what generally happens in a lot of these studies is the patients that got early CRRT tended to have maybe a little bit better outcomes, didn't show up in mortality, but related to other things. But they also had sort of more complications related to like central dialysis catheter replacement, clotting, things like that. The interesting part about the later group is even when they were enrolled, a good proportion of those patients, like maybe up to even 40%, didn't actually get dialysis, right? So early versus late. Still looking for the answer, but I think in the ICU world, at least in the adults, there's really no difference in mortality. But our children, just like little adults, I feel like I have to say that every time we chat about these things. Kind of hot off the presses, this is from the We Rock data set. I don't really remember what that stands for. About 1,000 pediatric patients, multi-center, multinational registry, looking at acute kidney injury and specifically looking at the timing of CRRT initiation. So they looked at those major adverse kidney events in children and young adults in the ICU environment. And what they found was the longer you wait to start CRRT, the higher the mortality. That's the one on the right. The longer you wait to start CRRT, the higher probability of having one of those major adverse kidney events. And that's a composite outcome: death, doubling of the creatinine for a prolonged period of time, or needing to go or going on CRRT. And so the data kind of reflects that, at least in children, early CRRT may actually be a pretty good thing. So in summary, fluid overload bad, kidney injury bad, prevention good, and there may be benefits in children for early CRRT. Now, what about all the high-quality studies in pediatric surgical patients? They don't exist. So I would encourage everyone to talk to Vince, talk to others in your critical care colleague universe, because these are really important questions. They're impacting your patients, and we really can make a difference in this. Thank you very much.